She figures she contracted it in her early 30s, so about 20 years ago, when she had shared a needle with a man who she found out had Hep C. She remembers years ago seeing a GI doctor, and they did a liver biopsy and told her that she had the Hep C and it was genotype 3. Again, never really pursued anything more. And then she had had a relapse just to pills about 6 years ago for about a year. She hadn't used injectables for many years. And so she's been in MAT program, and they were the ones that encouraged her to try to get this treated, which is how she got to me, because she has been clean and done well on the Suboxone for the last 5 years or so. Her comorbidities: hypothyroidism, depression, GERD, iron deficiency, hyperparathyroidism, and hypertension. I have her meds all listed there. She's been vaccinated against Hep A and B. So her labs do show that, yes, she is genotype 3, as she had said she had found out years ago. Her viral load, 323,600. Her Child-Turco-Pugh class A MELD of 6. Her liver function tests have been normal, normal platelet counts. We did the serum fibrosis score was at F0. So I think she would be a good candidate for treatment at this point. And I was thinking Mavyret or Epclusa. I did talk to her about omeprazole, and she said she can do without it.
Thank you very much for your case. Does anybody have any questions before we go into the comment portion?
Hey, this is John. Just one question, and this is to learn from the patient. Did she tell you why she ignored it for so many years? I'm always interested to hear why people don't pursue treatment, and then what made them come back. Wondering if it was the commercials on TV or.
So at the time she was seeing GI, I think the only treatment option she had, interferon, in that she was not really interested in. And then, yeah, she didn't know that there was really newer treatment, and said she felt fine and just really didn't keep it in the forefront of her mind for years. And she just recalls that they had said this was what they had to offer. And then it was when she got into our MAT program that they are the ones that told her, you know, there's newer treatment these days, pill treatment, it's much simpler. You really should do this. You've had Hep C for a long time. So that's why she ended up.
That's awesome. Good advertising by MAT. Yeah.
Yeah, really.
Elizabeth, should I go ahead?
Yeah, go ahead. Thank you.
Right.
I was going to say.
No worries. So the only questions I had written down also was about the Hep B labs, but actually I think you documented her as being immune. So
She is immune. Yeah.
Mm-hmm. As long as her surface antibodies positive, we're good. Yeah, 100% agree with you. Mavyret 8 weeks or Epclusa 12 if she's willing to hold her PPI or do that inconvenient dosing regimen of taking it some time period after that's hard to do. But you know, she's genotype 3, so you really only have 3 treatment options. So Mavyret, Epclusa, or Rivocevi, which is that, you know, the sort of treatment failure option. And you know, I usually will always prefer the shorter duration if possible. So Mavyret for 8 weeks would be fine. The only thing I thought was funny in her case is she literally has 20 years of genotype 3 infection, and yet she has by APRI and FibroSure no fibrosis. The only thing, not that I'm apt to or not believe that, but I probably would get an ultrasound on her at some point just to make sure that she doesn't have, some, not even an elastography, just a routine ultrasound to make sure she doesn't have some gloriously obvious cirrhotic morphology. Because, none of these non-invasive biomarkers are perfect. I'm assuming if she got a biopsy years ago, she was, not cirrhotic or anything at that point, but it's surprising. 20 years of genotype 3 and nothing.
Yeah, she did have an ultrasound. Sorry, I didn't probably put that in there. In May of 2021, and it just said no ultrasound evidence of discrete hepatic lesions. The liver was grossly normal. So again, she's assuming she's had it for 20 years because she was in her early 30s when she shared this needle. Potentially, maybe it was later, but I hear you. Yeah.
That's great stuff. So yeah, I guess I'm apt to believe it. And then she wouldn't need long-term HCC screening, and she'll very likely be a cure with either Mavorite or Epclusa if she was
Awesome.
a guy. So yeah, good job. I don't have anything else to really add to that case. Good stuff.
Thank you so much.
Thank you so much for submitting the case, and thank you, Dr. Gilfus, for that feedback. All right, if you have any other questions, please reach out. Dr. Root, are you ready for your 2 case presentations?
Yes.
Excellent. All right, I'll go ahead and share your first one. Give me one moment.
Okay, so my first case is a 54-year-old female that's been kind of a longstanding patient of our clinic. She was diagnosed with hepatitis C in 2004. Her pertinent history is she did use IV and intranasal drugs between 96 and 2006, and she was incarcerated between 2000 and 2001. She does have tattoos and piercings, but they're all professionally done. No other risk factors that I could identify. She has a history of chronic pain, GERD, and asthma, for which she takes omeprazole, tramadol, nortriptyline, ibuprofen, Cymbalta, and she's on Miralax because of the tramadol. For hepatitis vaccinations, so she is hepatitis A immune. She has hepatitis A IgG was positive. She is hepatitis B non-immune, but she has received her hepatitis B vaccine series. Her BMI is 25.4. Lab work wise, her H&H and white count was normal. Her platelets were normal at 291. Her CMP, her creatinine was 1.16. That was kind of elevated at that time. We've had one since then that was 0.81 with a normal GFR. Her LFTs, AST and ALT were 29 and 24. She had a vitamin D level that was normal at 65. Her HIV was negative, genotype 1A with a viral load of 11 million. Fibrosis marker was F1, and then her Hep B surface antigen and antibody were both negative. So for her, I was considering Epclusa or Mavorite because of her insurance being Medicaid. But from previous discussions, I remembered that her omeprazole might cause a problem. She does have really severe reflux if she misses a dose of that. So I was thinking maybe Epclusa with the restriction of 20 milligrams of omeprazole 4 hours afterward. And then another question I had was for her Hep B vaccine. So she has completed her Hep B series, but she's still not immune. So I didn't know if I needed to give her another vaccine or if I should just send in her vaccination series completion, and that would count.
Thank you so much for that first case. Any questions before we go into the comments? I believe both Dr. Gilfus and Rachel Mitchell have feedback for that. I'll keep that up with all the questions on there for you all. All right, no questions. Go ahead and unmute if you have any feedback for Dr. Root.
All right, this is John. I'll go first and then hand it over to Rachel, because for some reason I have an absolute mental block about the time frame with co-administration of these medicines and omeprazole. I think Dr. Root is right on there. But just the first thing that comes to mind this situation is, again, 25 years of hepatitis C and not much fibrosis. That's awesome. We're an F1 with a normal APRI, and that's all good news. So hopefully she's one of these people that is just a long-term slow progressor. And once you start ticking the years by, she's 50, you can start seeing accelerated fibrosis, more common in men and obese people, but it's certainly a good time to get her treated. By the way, kudos to her vitamin D. I don't know if that's you doing that, or if she maybe spends some time in Florida or somewhere that actually has sun. I don't know, but it's impressive. Vitamin D looks good. Looking at her genotype 1A, our treatment options are any of the 4 major drugs: the Zepatier, Harvoni, Mavorite, or Epclusa. Harvoni doesn't have, remember, we sometimes have an attraction towards Harvoni because it's 1 pill once a day, and you can sometimes do short courses for genotype 1s of 8 weeks, but that's only if the viral load is less than 6 million, and hers is 11 million. And so that really rules out short course Harvoni, and so there's no real attraction to going to that route. I would probably, if she really has bad GERD and is PPI dependent, give her Mavorite for 8 weeks. She won't need any long-term HCC screening, so life should be good from that perspective. She should be a cure and done when all's done. Your question about the Hep B is always it's a great one. My answers to that are, as usual, more questions. So I guess my question is, do you know how long ago her Hep B series was? That would be one question. And then the other one is how certain we are that she has, does she have any ongoing genuine risk for Hep B? So, we always universally say everybody with Hep C should get hepatitis B and A vaccinated. The hepatitis A passes the logic test because there's no way to necessarily avoid hepatitis A. There can be foodborne, fecal oral, wrong place, wrong time. Hepatitis B requires a much more overt risk factor. And if we know that she doesn't have a sexual partner with Hep B and doesn't use drugs anymore and is not a healthcare worker, her risk is probably really low. That being said, all the books will say vaccinate her, make sure she's immune. And if her vaccine was a long time ago, and she doesn't have ongoing risk factors, I think I would just submit her Hep B series and call it a day. If she does have any ongoing risk factors where you really want to make sure she's protected, the recommendations are to undergo another repeat series, and it can be any of the vaccinations, the old-fashioned recombinant one or the new fancy Hep B Slav or whatever it's called, the 2-shot series. So hopefully that answers your question, but great job. And then Rachel, if you want to remind me for the 10,000th time about PPIs,
Sure thing. So the weird administration, remember they're different for Epclusa versus Harvoni, just because of the way they did the studies and made sure that that those pharmacokinetics to see the alterations in the concentrations. But with Epclusa specifically, the recommendation is to take the Epclusa with food and then take the omeprazole 4 hours later. And it's not at least 4 hours. That's one thing I always stress to patients, because they think, well, I'll just, take the omeprazole before I go to bed. And in order for, the gastric acid to kind of return to normal, that's how they studied to see where we're going to get the best, dissolution of the Epclusa. It's going to get in the body the best is Epclusa with food, and then the omeprazole 4 hours later. So I usually give the patient specific time frames. What time do you think you're going to take the Epclusa? Are you eating at that time? Okay, so if it's going to be at this time, that means you take your omeprazole at this time, and then we work with their schedule, whether it's cell phone alarms or something, to make sure that they're able to kind of adhere to that as best they can to avoid that interaction altogether. And the dose of omeprazole has to be 20 milligrams once daily. It cannot be any more than that. So there is that max dose recommendation, which I think, looking on here, that was the dose that she was on, was the 20 milligrams, I think is what was noted. And then from a submission to just a piggyback on the hepatitis B serologies, I think rational drug would would prefer that there were some immunity just to see that there's not going to be any additional liver injury. But if you submit the series and don't submit titers for the authorization, they will usually take that as evidence of Hep B vaccination. But if you submit both with the titers, they will deny it.
Okay.
And no one on here is going to get me in trouble with RDT.
Never. We appreciate your insight.
Thank you so much, Rachel. That was great. And we did have a chat come in. Bearcat, if you want to expand on that, that's great feedback. Really appreciate that. So you can go ahead and unmute, and we are still taking down those recs, remember, so we'll send those over to you too and include those notes.
It's all the same thing, whatever Michelle said.
Excellent. Thank you so much. Really appreciate that. All right, I'll pull up your next case. Dr. Root, give me one moment, please. All right.
All right, so this patient is a 61-year-old male. He recently moved to our area to live near his sister. He was diagnosed with hepatitis C, he says, about 20 years ago while he was in jail. He did use IV and intranasal drugs between 1975 and 2011. His last use was in 2011, and he does have a tattoo that was done while he was incarcerated in 2001. He said he's been incarcerated many times in and out, but most recent was in 2011, and that was in Morgan County, Tennessee. He has no other known medical problems and no medications on a daily basis. He is non-immune to hepatitis A, and he is immune to hepatitis B. His BMI is normal. His lab work, his CBC was completely normal. His CMP, his glucose was a little bit high, but his LFTs, AST was 85, ALT was 111. His CTP class A MELD score of 6, APRI of 1.4, vitamin D level was 45, as genotype was 1, viral load was 1.8 million, serum fibrosis marker was F4, Hep B, he's a core positive, surface antigen, and E antigen negative. I did do a Hep B DNA that was negative, not detected, and E antibody was also negative. Because of his serum fibrosis marker being F4, I did get an ultrasound and do an AFP. The AFP level was 8, and his ultrasound didn't have any concerning findings on it. So at that point, I was awaiting his HIV screen. He has gotten that done since then, and it was negative. So one of my questions for him was, when I submit the paperwork, he actually is Medicare, not Medicaid, so I mistyped that. I don't know. I think actually he's Medicaid. I don't know. So he's Medicaid. So when I submit the paperwork, I know they took away the restriction that you have to have 2 viral loads 6 months apart, but it's still on the paperwork. So if I just submit it with a 1 viral load, are they going to accept it, or are they going to kick it back to me and say that I have to have that second viral load? And then for him, because his core antibody was positive, should I do a CMP like every 4 weeks during treatment just to make sure?
Thank you so much. Does anybody have any questions before going on to the recommendations? If you do, you can always come in later or chat those in. All right, we're ready for the feedback, please.
Oh, hey, Dr. Root, it's John Gilbert. Beautiful management on the patient. Well done. Excellent workup. So let me look through the questions here. In terms of priorities, this guy is exactly who you want to treat. By the way, I chuckle when I see he's on no medicines and no comorbidities listed, yet he's sitting there as a compensated cirrhotic. That's awesome. I'm glad that he's done so well. Out of curiosity, does alcohol a big part of his life throughout his 61 years so far?
He did used to drink, but he says he hasn't drank in years.
The reason I ask is, it's you always look for that cofactor or something that's going to push them up to have such advanced fibrosis. So the first thing we'll do is talk about the management and really genotype 1. We don't know if it's an A or B, so I'd avoid Zepetir since that would require extra testing. Mavorite for 8 weeks, Epclusa for 12. And then remember, as I mentioned, Harvoni can still be an option for genotype 1, and he has a viral load of less than 6 million, but big pause. You can't do short course for Harvoni with cirrhotic patients. And so Harvoni would be 12 weeks as well and offer no advantage over Epclusa in that scenario. So again, the choice comes down to the patient. Does he want to take Harvoni for, I'm sorry, wrong word, Epclusa for 12 or Mavorite for 8. And he'll have good success with either. And of course, he has advanced fibrosis. Thank you for getting his ultrasound, and he would need that indefinitely every 6 months to make sure he doesn't develop a HCC and plus minus on the EGD referral for varices. If his ultrasound definitely showed that he has cirrhotic morphology, I would go ahead and refer him to for EGD. If this is just a pessimistic F4 on a serum biomarker, I don't know that I would. And, you know, there's his APRI is above 1, but his platelets are only 150. So a lot of times, if you're somebody with a lot of portal hypertension and true advanced cirrhosis where you're going to get varices, your platelet count will be even lower than that. But so I probably base it on whether I send him to GI for endoscopy would be based upon the actual morphology on his liver ultrasound. Now, getting into your last question about the hepatitis B core antibody positivity. So clearly he did have natural exposure at some point in his life. And thank you for putting the quantitative surface antibody. So his quantitative surface antibody is 95. That's very good. So his body has formed an excellent immunologic response and controlled his hepatitis B. In that scenario, hepatitis B sort of exits the equation. So I know we always talk about Hep B and Hep C co-infection and the competition between those two viruses. But once your body has established surface antibody positivity, that whole phenomenon goes away. So your worry and concern is now nil. You don't have to worry about it or think about it at all. So I wouldn't, it's only becomes an issue if your body has not formed surface antibody. In those situations, you need to sort of follow things routinely from the Hep B standpoint after treatment, but not in this scenario. This scenario, you're done. You're happy. Your Hep B is gone. Well, not really gone, but it's not coming back. Now, I would still, however, do a little bit more frequent labs on this guy than a lot of times. Gosh, the labs we do is prior to treatment and then end of treatment sometimes, and then the SVR 3 months after the last dose. In a patient like this who's cirrhotic, especially if you're going to use a protease inhibitor like Mavorite, I would monitor their labs at least one time while they're on therapy. So I would just pick a middle of the road time period and check it just to make sure you're not having anything. And of course, counsel the patient if they start developing anything to suggest an acute liver injury from a drug. So anything that would be like GI issues, loss of appetite, dark urine, etc., to hightail it into CU. I hope that made sense. And then the last thing I'm going to do is hand it over to Rachel to see if she can give good advice on the Medicaid changing the criteria for having 2 viral loads. You're right on. That's a wonderful thing. You know, that the concept that Medicaid was using 2 viral loads was to prevent us from inadvertently treating acute viral Hep C. So that the concept is that certainly an unrecognized minority of people do clear hepatitis C on their own. That number always quoted as, maybe 10 to 30% of people. So obviously, while these drugs are expensive, the payers were trying to ensure they weren't going to treat somebody who would clear on their own. So that was the way that they corrected for that was ensuring someone actually had a definition of chronic hep C, which is having active viremia for 6 months. But they changed that. And so that does mean some people are inadvertently going to get their acute hep C treated. And that's okay. I'm not complaining about that. But in terms of Rachel, do you mind tackling the fact that their form is still goofy? Do you have any comments on that?
Sure thing. So really, you can just leave that other one blank. We've not had any issues where they've kicked any of those back. It takes them some time to update the form. I don't know, in West Virginia Medicaid land, who has access to, edit PDFs to be able to make those updates. So it will take them. It usually takes them a little while to catch up. But we've been submitting them thus far with just the one viral load, and they've not had any issues. They're taking them so long as they're recent within the last 6 months.
Great. Thank you so much.
The only other thing, I'm sorry.
No, I'm sorry.
No, you're good. Hey, Jessica, does that make sense about the Hep B stuff? All that?
Yes.
Okay.
So-
Yeah, and just for the rest of the listeners on there, that I don't want to give the false impression that you never ever worry about hepatitis B again if you have a surface antibody positivity. It's just you don't have something of Hep C, co-infection and treatment. So there are certain situations. Remember, hepatitis B is a DNA virus. Even if you've developed immunity, if you go ahead and get a bone marrow transplant or get put on one of those anti-CD20 drugs for certain autoimmune conditions and lymphomas, you can reactivate any DNA virus, including Hep B, where you have immunity. But it takes a really, really profound hit to your immune system, and so not the situation we're worried about with the Hep C drugs.
Thank you so much. Do you have any further questions, Dr. Rude?
I don't, thank you.
Of course. All right. Jennifer Boyd, are you ready for yours? This will be our last.
Ready if you are.
Perfect. I'm always ready.
I noticed.
All right, go ahead.
Okay. It's been a while since I've seen this lady, and I don't know her real well. She's a 46-year-old Caucasian female. I've only seen her by telehealth. She was diagnosed at our organization in 2018. She does have a history of IV drug use, as you can see, from 2009 to 2013, but she's been sober since 2013. She had a blood transfusion in 1990, non-professional tattoo in 2014, and no other risk factors. She is unvaccinated. She's not immune to Hep B. One issue with this person is we have a hard time getting her to come in for follow-up, whether it's blood work or vaccinations, and I can talk more about that later. Her Hep A total antibody was positive. She's, as I said, 6 years sober. Her current partner is a female. Well, actually, she's married to a female, and so doesn't use contraception. She does have a history of anxiety and hypothyroidism. Yes, you can scroll down. Thank you. She's technically obese with a BMI of 31. She was looks slightly anemic. I'm not sure what the normal was on our lab for hemoglobin, and I could look that up. Platelets were normal. You can see the other chemistries there are normal. Liver functions were within normal range. APRI 0.1, class A, child troponin, and a MELD score of 6. Her vitamin D was 30. I did start her on supplement for that. She's HIV negative. Her Hep C genotype is 1A, and her viral load was 522,000. Her serum fibrosis marker gave her F score of F0. There are actually two barriers to taking care of this lady. The first is what I already mentioned, that she's just tricky to follow up with, and she has a connection to our organization. So I don't know what her deal is. She just doesn't follow through on stuff. But she's always, when I do reach her, she's always really happy to be, interacting with me. And I don't really have any concerns that this is related to her sobriety. She's very stable. I think she's just very busy. But she does not have health insurance. And that's something that we can work with her on. So if I were, choosing medications to treat her based on her genotype, I would think Harvoni, Epclusa, Mavyret. And if I am not mistaken, I think that Harvoni has a patient assistance program. But if anybody has any feedback on that, in the case that we're not able to get her insurance. I think that's everything. I didn't get, I don't think I got an ultrasound on her because her F score was so low, and because I think that her infection probably was fairly recent during her history of IV drug use. I'm double checking to see if I did do an ultrasound, but I think I didn't do one. Nope, I didn't. So that's the story.
Thank you so much, Jennifer. Appreciate that case as well. All right. Any feedback for Jennifer on this case?
Hi, Jennifer, it's John again. Good to hear from you. Always.
Yes, nice to be here.
Yeah. And it sounds like you got a good relationship with her. And I like that you gave her credit for being busy, not neglectful of her health care. That was a beautiful statement. I appreciate that. So just one thing, and by the way, I think like 3 out of 4 of these cases or something have had thyroid issues. I want to just point that out, that, thyroid disease and hepatitis C had a long relationship. And yeah, it's funny. It's not always causative, but, most hypothyroidism and even a lot of hyperthyroidism is autoimmune in nature. And there's definitely a relationship between the two. Not that it's going to get better, unfortunately, if you treat the Hep C. But it's just, I thought it was interesting. A lot of these ones we presented today, all have thyroid issues. It tends to be one of those potential extrahepatic relationships that we see. No fibrosis, no long-term HCC screening. And I agree with you that she probably doesn't need an ultrasound. Probably does not. She's about 10 years of infection, we think. Now, technically, her blood transfusion in 1990 still is a potential risk. Remember, it was the 92, 93 when the blood became safe. But we'll play the odds. I think everything's telling us we got good news here. Harvoni 8 weeks, Mavyret 8 weeks, or Epclusa for 12. And again, the Harvoni for 8, because we got the low viral load, less than 6 million. She's non-cirrhotic, not immunocompromised, so we could get away from it from that perspective. I wouldn't bother with the Zepatier because it requires more testing with an NS5A polymorphism. And the drug assistance programs, really your options are, if she doesn't have insurance, is drug assistance programs or buying it abroad, which is a perfectly valid option if she has $600 and is really that busy, because filling out the paperwork is takes up tad of a motivated patient to do this stuff. The patients I've had fill it out have loved the Gilead process, which is, the Harvoni and Epclusa. I can't remember off the top of my head anybody who's done the Mavyret drug assistance program, but I'm sure they have one. But I've had rave reviews from a couple of patients who actually did the Gilead process. And Rachel, I don't know if you have any better advice on that one.
Yeah, so we here traditionally don't handle the PAP because we have the social workers in the clinic do that because they're way more experienced with those PAP programs. But Gilead does have one called Support Path for both, for Harvoni, Epclusa, as well as their generics. So technically that's not Gilead, it's Aswega, but it's still really Gilead. And Support Path is for both brand and generic. So the generic ones are like a third of the cost. So that, I think that's, a viable option for getting free drug in that aspect. AbbVie is the manufacturer for Mavyret. They do have a program. I've seen a couple patients get some Mavyret from that perspective. And most of that stuff is available online to get started. And I don't know, Dr. Gilfus, if your patients have told you specifically. I've had several patients, it's in my mind, it runs in my mind that they send the full course of treatment. So they don't do like follow-up refills like we do, because usually the insurance makes us do 1 month at a time. But I think since it's not through insurance, I've had patients tell me they send them all of the treatment at once, which is, good and bad. But in this case, if it's a patient where you're concerned about follow-up, maybe if, you're worried she's not going to answer the phone or something, that might be a bonus.
Awesome.
But they do really good with case-by-case basis on income. So don't ever, I've had patients say like, I make a good income and they're not going to approve me. But these medications are crazy expensive. So they're really good options on a case-by-case basis.
I don't know how I neglected this, or maybe I didn't, but I didn't see it on the case form just now. I did not list her current medication.
Yeah, I had a question on that too. I wanted to.
Right. So she is on buprenorphine. She's also on Lexapro, gabapentin, levothyroxine, and she has an as-needed Zofran prescription on her med list.
To my ear, that sounds fine. I don't.
Yeah, she's good from clinical interaction. So, and if you get denied in some weird instance, you get denied by support path, try AbbVie.
Okay. Thank you guys very much.
Thank you so much. And we also had a comment come in saying, I think the Harvoni Patient Assistance Program requires a call if they don't have insurance already as well.
Okay.
Perfect. Thank you so much. All
Elizabeth,
right.
I have a really quick question, because I know it's tight for time, but has anybody ever prescribed for somebody with Medicare? And I know there are all these different, I'm just curious about Medicare, what they cover and how hard it is to get things covered. I know there are, all these different Medicare Part D programs. But I had another health center who's thinking about starting to do Hep C treatment asking me about that. So I said I would ask today.
I've done a couple actually, and they have not been as much hassle as Medicaid, but as you say, it depends upon their program. There's always some extra prior authorizations and stuff to do, but we've managed to get it for our Medicare patients.
Good. And is there a copay? Do you recall?
There again, that varies, I think.
Okay.
And sometimes that is kind of prohibitive, but we've figured out ways around it for some of them. So.
Thanks a lot, Dr. Rector.
Yeah, from a Medicare perspective, and labs and things usually a lot easier for criteria. And don't forget with Medicare, you can use foundation assistance for their copays, whether that's through Patient Access Network Foundation, which we always call PAN. American Liver Foundation has funds as well that you can utilize. And they usually, what they do is they'll approve like $7,500 upfront, and if the patient needs more, they'll approve an additional $7,500. So depending on what their copay is, usually that's enough to cover.
Terrific. Thanks a lot.
Great. Thank you so much. And Alice, I know that previously you had sent that information over about a patient and we had some excellent feedback. I just didn't know if you had any further questions for the group here.
No, I passed that on to Dr. Bailey and to Robin about what to do for this patient. I don't know if you want me to tell everybody about what happened, but she was picked up on a warrant. She was 6 weeks into treatment for Mavreat. She was picked up on a warrant, spent 90 days in jail. Her mother tried to get her medication, and even the counselor from Southern Highlands tried to get her medication, and they would not accept it. So she had to spend the 90 days there without her Mavreat. So then when she got out, she came to Robin wanting to know what to do. So she did have a PCR, which it came back non-detected. So I passed on the information that the program gave me to give to them about further treatment options. Thank
Great.
you.
Thank you very much. And thank you everyone that did chime in for that. You guys are seriously rock stars with cases. I just want to say we have so many cases are backed up. We were discussing maybe even the next session. I know, I'm sorry, we are running short on time. I'm going to get right to Dr. Gilfus, but if we have to stop in the middle of your presentation, maybe we can continue at the next time if that's okay, and maybe try and push some of our cases into that as well. I don't know, we're gonna have to need another day of cases, I think, coming up maybe, but we really do appreciate all your hard work, everyone. Dr. Gilfus, you have capability to share your screen, so whenever you're ready, just don't feel rushed, just get to where you want to.
Cool. And by the way, Alice, for that one, so the patient was undetectable, even though she didn't complete her course? Is that what I'm hearing?
Yes, she
Wow.
was, after 6 weeks, she was undetectable. And I think the recommendation was to test her again in a month. And to make sure that not even take any more medicine, just see how she was in a month.
Yep, agreed. I'd even suggest you do one more, another maybe 3 to 6 months down the road, just to make sure whenever we have those atypical treatment regimens, sometimes it happens. Even in the interferon days, every once in a while we'd get cures after a month, and same with these direct-acting antivirals. Cool story. Yeah, I'll share my screen. This stuff is this is a really low falutin talk, because you guys are all experts at it, probably better than I am at it. Share screen. Here we go. And so since everybody on here is honestly an expert at this stuff, your initial evaluations and everything else, feel free to correct me or add whatever as I'm going along. But basically going to talk about what do you do when you first want to meet a person who has HCV. And yeah, these are our objectives. Due to time, I'm not going to read those to you. But first thing we want to do is, of course, let's make sure that the person actually does have active hepatitis C. So not just antibody positivity, but PCR testing that demonstrates they have active infection. We kind of talked about that in the cases today, that some people will clear. And you can see I have up here the statement that most people clear in the first 3 months. I've seen a very small minority of people clear past that. I've seen some people even clear spontaneously after a year. But in general, if you had positive PCRs for 6 months, you got chronic hep C. Now, probably the most important thing with talking about their risk factors and all that is trying to get a timeline. And again, the whole goal there is we know they have it. Does it really matter what the risk factors are? And the answer is only if they're ongoing for reacquisition. Genuinely, that's the major thing that matters. But it's important to talk about what the risk factors were for more than anything, to figure out how far behind the 8 ball we are. Did they use drugs? Did they get a transfusion? Did they have an unsterile tattoo, 10 years ago or 40 years ago? And as we know, the natural history then dictates how concerned we need to be. One of the things I have found very useful, because people a lot of times have ongoing risk factors. It's just been an issue in their life for a long time. So it's hard to pin down when it might have got them, when they might have acquired the hep C. And using this history of any prior negative tests, I've had that very, very helpful a lot of times, where people have, started a new job or unfortunately got incarcerated or something and got hepatitis C testing in, say, 2014, 2017, and then turned positive in 2019. And so you have a good time frame there if you know about those prior negative tests. And of course, asking about any prior jaundiced episodes. That's how I tend to ask that. Do you have any prior episodes where you had an acute hepatitis type symptoms, including jaundice episodes, or anybody who's worried about your liver? And of course, defining if they have any prior treatments. Screen for other illnesses that share transmission mechanisms. And hep B obviously shares nearly an identical transmission mechanism. There's more sexual transmission with hep B, more mother-to-child transmission with hep B, especially worldwide. But in the United States, a lot of the transmission we do see is IVD related. HIV, of course, shares the IVDU mechanism of transmission. Now, hepatitis A, we tend to think of having a fecal oral spread or food-borne spread, but there is a transient viremic phase, so you can't actually get hep A from IVDU. And then, of course, risk behavior in the drug use setting can beget risk behavior in the bedroom setting. So STI screens and syphilis testing, especially the syphilis testing. Remember that STI screens may or may not be that useful because if you're asymptomatic, I'm not sure how much it always matters, but syphilis does matter. You got to treat that one. You got to find that one, treat that one. That can hurt you long term. What labs do we do? And honestly, the very, very best practice for this is filling out your echo case submission. So get Elizabeth some cases and you'll get good practice in this. Just to look through them real quick, the ones that I don't always include on the case submission form, an A1C, a hemoglobin A1C, and a TSH. We kind of talked about why the TSH today, but the A1C, diabetes and Hep C do have a relationship, and it's a double negative relationship where hepatitis C can cause a patient to actually have poor glycemic control and develop frank diabetes, and vice versa. Having diabetes can make your hepatitis C progress more rapidly. So that's something important. Genotype, so you can help pick drugs. Fibrosis, we'll talk about in a little bit. And we talked about the other co-transmission pathogens. The vitamin D levels are important because the issue with vitamin D in the viral hepatitis is honestly better worked out for Hep B, but we make assumptions with Hep C that it matters too. And the lower the vitamin D, the more rapid the rate of fibrosis potentially. That's at least the dogma for Hep B. Why you do a urinalysis has to do with extrahepatic manifestations. So what you're looking for is glomerular disease, glomerulonephritis, that can accompany Hep C as a form of extrahepatic manifestation. Same here with the rheumatoid factor. And so rheumatoid factor, which is a marker of some of our polyclonal hypergamma-globulin production that you see with Hep C, you can screen with the rheumatoid factor. And if it's positive, you want to see if they actually have genuine rheumatoid arthritis. That's what the CCP is for. But rheumatoid factor is also a nice screen that you can do before bothering to order cryoglobulins, because cryoglobulins are hard to order. Half the time the lab tells you that they did it wrong and you don't get them back, and it's expensive. So I tend to screen with rheumatoid factor and only go on with cryoglobulins if it's positive, which does have some support in the literature to do that. Now, I tend to be really remiss about screening for additional chronic liver diseases. I don't think we have Gene Kernel on, our hepatologist. I know that if you see a GI doctor, they do a much more profound initial screen for other chronic liver diseases than I do. I tend to be an infection doc, so I focus on infections. And every once in a while, I'll remember to check iron studies. But I know that our GI doctors do a little bit more profound workup initially for alternative or additional liver-related diseases besides Hep C if you have someone with transaminase abnormalities. So they'll do iron studies, autoimmune hepatitis. They'll do some of the genetic disorders, etc. Now, I personally don't do the urine tox screen. I would only do that if the payer or if you're personally interested, or you may be in an MAT program and that matters to you. I've never actually, genuinely never had to order one, the urine tox screen. And of course, a pregnancy test is important because these drugs, we don't know that they're not safe for pregnancy. It's just, we just don't know. We don't know if they are safe. So you have to document the patient is not pregnant. So after you order your labs, or even before you probably order your labs, you're going to talk to your patient about the natural history of Hep C. And we already talked about establishing that timeline. And I always try to share with them this rule of thirds that I quote as saying inaccurate but convenient. So the rule of thirds is that if you have 3 people in the room with hepatitis C, 1 out of 3 will never have any liver-related morbidity or mortality at all. They won't develop anything. 2/3 will develop some degree of liver-related damage, and 1/3 will go on to develop cirrhosis. That is actually not true, but boy, is it easy. So I use that analogy. If anything, it is underestimating the people who have some degree of liver damage. So that second 2/3 is probably tad higher. And it's actually overestimating that 1/3 that goes on to develop cirrhosis. That number is actually probably lower, but whatever. We do things for convenience. So, oh yeah, and this education can obviously make people feel good. It can make them feel good if their acquisition was recent. It can make them feel nervous if their acquisition was decades ago. So just kind of good education to share. And by the way, this is all talking about fibrosis related issues. It doesn't correlate with the extrahepatic stuff. And so you could have somebody who doesn't have liver damage, but could potentially develop lymphoma or some other scary consequence of Hep C. So certainly basing treatment decisions or anything like that on fibrosis alone is not recommended, because you got other issues that you can help with if you treat them. This is a cool slide because I've been able to change it in about the 10 years that I've had it. We used to just be like, no blood or organ donation. And now some programs will permit organ donation. And actually that's made some people happy. The other thing with that is obviously after you treat someone for their hepatitis C, they could definitely donate organs. Their blood will still be rejected because their antibodies stay positive for life. Even though they're not contagious, their blood will be rejected. So no reason to donate. But prevention of transmission around the household contact is also a very important part of education. I just had a patient the other day ask me if they were contagious riding in the car with their loved one on the way over. And so they're really, people are good people. If they know about something, they really don't want to transmit a virus. And part of the education we do is letting them know exactly how hard this virus is to transmit. You can read things that are a bit intimidating, like hepatitis C can survive on the surface for 3 weeks. That's true, but you'd have to directly inoculate it percutaneously to have it cause trouble. You're not going to run into hepatitis C acquisition just from contact through an intact mucous membrane or a or skin. So it's really got to be a cut, scrape, blood-to-blood transmission or virus-to-blood transmission. Oh, yes, this one's very important. If they do have ongoing drug use, try to encourage them to do so as safely and without sharing any implements as possible. The issue with Hep C and sex is complicated. I think all of us have seen cases where we suspect there's sexual transmission in a heterosexual manner, but it's really infrequent. That the statistic is maybe 1% per year in a monogamous serodiscordant heterosexual relationship. That's a mouthful. So basically saying if you had a husband and wife who only had each other as sexual partners, one had Hep C, one did not, and they engaged in intercourse unprotected for a lifetime, it's about a 1% chance per year. Okay. That being said, if you have HIV or engage in MSM, so men who have sex with men, HIV in MSM, sexual transmission becomes actually genuinely common. Hep C becomes a genuine STI. And so we really do have to counsel our patients in that scenario to curtail their sexual practices, condom use, get treated, etc. Okay, and again, anyone who's been on the ECHO program for long has probably seen this slide 10,000 times, but I love it. It's one of these things that makes me do a gut check every time I see a patient and I start thinking all about their virus and extrahepatic stuff and going down that pathophys thought process to not forget about the human in front of us, because the risk factor that led them to get hepatitis C is genuinely the most likely thing that's going to kill them. And that's always, and that's what I'm absolutely the worst at is mental health and drug counseling and assistance. And I would need someone much better than myself to make sure they stay in a good place and stay safe from that perspective. So, but remember, how important is that? It's actually the most important thing we're going to do when we see our patients with that as part of their history. Because overdose and suicide is what kills patients much more rapidly than cirrhosis and HCC. All right. So one of the things that we are not able to do as clinicians is necessarily determine exactly how much fibrosis a patient has, just based on our routine history, exam, blood work, etc. And that's sometimes we can. If we get a patient who's gloriously overtly cirrhotic, you never want to see this, but if you do, you can make that diagnosis. You know how much fibrosis they have. They have cirrhosis. And we'll talk about how you can make that diagnosis. But our goal is to try to get an estimate. And I think anybody who's done the ECHO program for long realizes that we struggle with this. And a lot of times what we're trying to do is collect as much data as possible and make our best educated guess. So remember the fibrosis score that we deal with this F0 through F4 is a holdover from biopsy days. Back in the days that people used to get biopsies routinely. The pathologist is the one who told us what the F score was. By the way, even with the liver biopsy days, there was differences in, you're taking one core sample and sometimes you hit a bad core, sometimes you hit a good core. So it wasn't perfect, even though we consider it the gold standard. And also pathologists differed a little bit in how they read them from time to time. So while we kind of hold this up as the gold standard of history, it had issues. It genuinely did. And it was terrible. Nobody wanted to do it. And we don't have to do that very often. We do still need to assess this fibrosis via non-invasive modalities so that we can figure out this stuff. So disease progression, outcomes, treatment, who needs to have HCC screening, who needs to go for EGDs, for varices screenings, etc. So it's very important. Our various modalities we have, again, the liver biopsy, haven't done one in 10 years, 15 years actually. We have those lab tests that we all see, those fibrosures and fibro tests that are amalgam markers of the biosynthetic and biodegradatory activities of the liver. We just order a lab and we get an F score. It's awesome. But it's some pretty cool calculations that go into that. And of course, the elastography that's going to give us a sense of how stiff the liver is. And that stiffness will correlate into a unit in kilopascals, which then means nothing to any of us clinicians, but then is turned into an F score, thankfully. So the stiffness turns into the stiffer the liver, the higher the F score. And then of course, our calculations with the APRI and FIB4. And our goal is to collect as much of that information as possible so we can, I stole this terminology from Dr. Feinberg. She's so good with her linguistics and she calls it triangulating. So I put on triangulate the truth. We want to use all available data to try to get our best guess as to how much fibrosis a patient may have. And sometimes there'll be a dominant component of that. Sometimes it'll be the lab that'll tell us. It'll be that F4 on our fibrosure, or it'll be an APRI that's sky high. But sometimes, honestly, it's the timeline or the clinical exam. So I have had people with F1s or F0s and low APRI or low APRIs, normal elastography, who I know are cirrhotic because they've had a history of a variceal bleed or have presented with cases of hepatic encephalopathy. So there are times when, even though we say the sensitivity is low on the clinical history and exam, there are times it's the dominant modality. And feel free to trust yourself in that scenario. Or if you know you've had an ultrasound or a CT that says you've got a patient with a little cirrhotic liver and dilated portal vein and big spleen, and yet your biomarkers don't agree with that, trust that dominant bit of data and go with that one. I hope that makes sense, but triangulate the truth. Collect as much data as you can.
Dr. Gilfus.
Oh,
I'm
yeah, I got
sorry.
to shush. Don't I? I can restart right here next time.
That sounds perfect. We could do
Okay.
that. We could do that next week, and
This
we'll
is-
just like
This
play
is
by ear.
a huge one. So I definitely don't want to blow over the HCC stuff. So,
We really appreciate that.
Oh,
Thank
you
you
bet.
so
Yeah.
much.
Yeah.
Yeah, just my announcement. You'll hear more to come for our next session. Really, again, appreciate all that you guys do, and I hope you have a really great rest of your week. We're almost to the weekend. Bye-bye. Thank you.
Thanks, everyone.